And now we move to postpartum fever. Postpartum fever is an indication often of an infection. These stamps honor two great scientists from our past. On the left side is Louis Pasteur, the father of modern bacteriology, who discovered the presence of bacteria. On the right side is Ignaz Philipp Semmelweis, who was an Austrian obstetrician who described childbirth fever. Unfortunately for Dr. Semmelweis, Louis Pasteur had not yet discovered bacteria. And Semmelweis had to do his work without even knowing what he was working with. Childbed fever was a very common cause of death for thousands of women throughout the world, and it still is today. Ignaz Semmelweis was at the University of Vienna Hospital in Austria. At that time, they had a midwife service and a medical service. In the midwife service, 1 to 2% of the women got childbirth fever. In the medical service, 20% of the women got childbirth fever and died. And he was trying to figure out what was going on. Well, at that time, they had no idea about bacteria, about sepsis, about cleanliness. And when the medical team would come in the morning, the first thing they would do is do autopsies on the women who had died the night before. They didn't need to wash their hands. They would examine women in labor and inoculate them with streptococcus. What triggered Dr. Semmelweis's understanding was his partner, who was a male obstetrician, was doing an autopsy, and the scalpel slipped, and he cut himself, and he got infected, and he died. And when they did the autopsy on him, it looked just like the women who died. And he realized this was not a male-female thing. There was something more going on. And here's what he wrote. Puerperal fever is caused by conveyance to the pregnant women of putrid particles derived from living organisms. He didn't know what to call them. He didn't know what bacteria were. He called them putrid particles through the agency of the examining fingers. Consequently, must I make my confession that God only knows the number of women who I've killed. And immediately he said, everybody needed to wash their hands between patients in this bowl of chlorinated lime. And immediately the death rate dropped. He was so excited. He wanted to publish this. But see, he was actually Hungarian. He was not Viennese. He was a minority. Why would anybody want to listen to a minority? And so it wasn't until after his death in an insane asylum, he went crazy, that his contribution was finally realized. And even today, when I admit patients with endometritis, I think of Ignaz Semmelweis. And here the doctors are washing their hands. All right, let's work through postpartum fever. And we're going to go through this in a chronological fashion. We're going to look initially postpartum day 0, atelectasis, wind. Postpartum day 1 to 2, urinary tract infection, water. In New York, they'd say, wada. You want some wada? Postpartum day 2 to 3 is endometritis, womb. So we have wind, water, womb, wound, day 4 to 5. And day 5 to 6, septic pelvic thrombophlebitis, walk. So we have wind, water, womb, wound, walk. Again, as we did with postpartum hemorrhage, we're going to look at risk factors, we're going to look at clinical findings, and we're going to look at management. Atelectasis pneumonia. This is postpartum day 0. Who is the most likely patient to get atelectasis? A patient with a vaginal delivery or a cesarean? Cesarean. Is it most likely going to be general or regional anesthesia? It's going to be general anesthesia for cesarean. Doctor, it hurts so much, I can't take a deep breath. I can't get out of bed. Atelectasis. Clinical findings. Mild fever, rowels. Going to get a chest x-ray? No. Management, pulmonary exercises. Encourage the patient to get out of bed, to walk around. General anesthesia for cesarean. We seldom do general anesthesia for cesarean. We usually use regional anesthesia. Postpartum day 0, fever, status post-emergency cesarean, general anesthesia, rouse on lung auscultation, atelectasis. UTI. This is postpartum day 1 to 2. Risk factors. Multiple catheterizations in labor. Multiple vaginal exams in labor. Is this going to be a short labor or a long labor? Prolonged labor. Whenever you have multiple catheterization, multiple vaginal exams, it's probably a prolonged labor. Clinical findings: fever, costovertebral angle tenderness, right side more than the left. On a urinalysis, you'll find white cells and bacteria, and ultimately the culture and sensitivity will show the organism and what the sensitivities are. The management, single agent IV antibiotics, will typically use a cephalosporin, and you always want to just check a urinalysis and make sure the patient is okay. Now, postpartum, remember, a voided specimen is going to be pretty difficult to get clean. So you probably need to do a cath specimen. Risk factors: multiple intrapartum catheterizations, multiple intrapartum vaginal exams, and bacteria from the vagina go up through the urethra, into the bladder, up into the ureters, up into the kidneys, and you have pyelonephritis. Fever, postpartum day 1 to 2, multiple labor catheterizations, costovertebral angle tenderness, that's going to be UTI. Endometritis. Endometritis, day 2 to 3, clearly is the most common cause of postpartum fever. Risk factors: vaginal or cesarean delivery. Cesarean. Emergency or scheduled. Emergency cesarean. And most emergency cesareans are done after prolonged rupture of membranes. Bacteria from the vagina get up into the uterus. Prolonged labor. Your risk factor is prolonged rupture of membranes, probably lots of oxytocin, failure to progress in labor, followed by an emergency cesarean. You don't see this very often if you have a scheduled cesarean without labor and without membranes ruptured. Clinical findings. A key finding is an exquisitely tender uterus. Midline. Now, after a cesarean, of course, you've got the incision, which is tender. And so that can be a little confusing. But the uterus itself is tender. Should you expect peritoneal signs? No. This is not an infection of the peritoneal cavity. You should have normal peristalsis. This is an endometritis. Now, it can become more than that. We'll look at that in just a minute. Should you get cultures? No, because you know what organisms are there. These are normal vaginal organisms. Gram-negatives, gram-positives, anaerobes, aerobes, everything. So we give broad-spectrum antibiotics. Typically, we will give gentamicin and clindamycin, and we'll continue the antibiotics until she is afebrile for 48 hours. She doesn't need to go home on antibiotics. That should be all you need. Exquisitely painful uterus. Think endometritis. And here's what happens. You have the organisms get from the vagina into the uterus, and they cause an infection of the endometrium. If that isn't adequately taken care of, it can become an endomyometritis. The myo meaning the muscle of the uterus. If that doesn't get taken care of, it can go further and it can travel into the perimetrium, and we have an endomyoperimetritis. And if that isn't taken care of, it can become a pelvic abscess. Fever, postpartum day 2 to 3, status post-emergency cesarean, exquisitely tender uterus, you better think endometritis. This is Henry VIII and his 6 wives. These 2 he divorced. These 2 he beheaded. These 2 died from endometritis. 1/3 of his wives died from endometritis. Very common cause of postpartum infection. Wound infection. This is going to be postpartum day 4 to 5. The risk factors: emergency cesarean, prolonged rupture of membranes, prolonged labor. Have you seen these risk factors before? They're the same risk factors as endometritis. Clinical findings: you may either have a cellulitis, in which case you got swelling, you got redness, you got pain, or you may have an abscess which is draining. And we're going to manage these differently. If there's a cellulitis, we're going to give antibiotics. If there's an abscess, we're going to open the wound and pack it. So, IV antibiotics for the cellulitis. If there's an abscess, the wound needs to be opened. Now, I have tried to be sweet and kind and gentle, just open up a small part of the wound. You've got to make sure the entire area is open. There are no pockets which are left in there. Now, this is postpartum day 4 to 5. So we've already ruled out urinary tract infection. We've already had the patient probably on antibiotics, and she's not responding. We've ruled out atelectasis. And this would be then wound infection, day 4 to 5. Here we have a wound that needed to be opened. And here we have corruption and junk in there. What are we going to do? We're going to pack it. Now, this was a patient who weighed 400 pounds. This incision is 34 centimeters long and got infected. What we need to do is to pack it. And you can see we put in these wet to dry packs all the way along here. And we want it to clean itself up and to develop granulation tissue. If you look carefully here, these little white reflections, this is granulation tissue which is starting. And you change the dressing 2 to 3 times a day. Can you see here, we have migration of the stratified squamous epithelium, which is going over this granulation tissue, and it will completely close this. Now, you're going to have a defect here because you don't have the subcutaneous tissue, but it can close by what we call secondary intention. Now, if the wound looks like this, you can see nice granulation tissue all over here, it's clean, we can just close it up like this and just steri-strip it. And now she can have a closure without secondary intention, and you won't have that big deficit without subcutaneous tissue there. This is a patient that came in with drainage from her wound. She was 436 pounds. And she said, I've got drainage from my wound, and I looked at it. What do you think this is? This is bowel. This is total dehiscence of this wound. When we took her to the operating room, which we did have to in order to close it, as they were giving anesthesia, increased intra-abdominal pressure, and out comes all this bowel. So we had to put it back in, and then put retention sutures, and she actually did quite well after. But there is no such thing as simple surgery. There are simple surgeons. But any surgery has its risks, and this is one of them. This is an even worse outcome. This is necrotizing fasciitis. And if you've ever heard of the flesh-eating bacteria, this is it. When I put my finger on this, it went right through, no pain whatsoever. None. How was this treated? Wide resection, block resection by general surgeons, and they took out this amount of tissue here. This is a life-threatening condition. She fortunately did very well. Okay, fever on postpartum day 4 to 5, status post-emergency cesarean, wound indurated red and tender, that is a cellulitis. IV antibiotics. Wound day 4 to 5, status post-emergency cesarean, but there is purulent drainage, that is an abscess. And that needs to be opened and drained. So the difference here is wound indurated red and tender, wound purulent drainage. Septic pelvic thrombophlebitis. When we think of septic pelvic thrombophlebitis, we need to think of what are the risk factors that create clots. And Virchow's triad is hypercoagulability, vessel trauma, and stasis. And those are all present when we have a postpartum cesarean patient. Risk factors: emergency cesarean, prolonged rupture membranes, prolonged labor. Have you seen these before? They're exactly the same as for a wound infection, exactly the same as for endometritis. Clinical findings: picket fence fever. Temperature goes up and down, up and down, up and down, up and down, and yet the patient feels fine, says, I want to go home. You've checked the urine, there's no UTI. You've checked the lungs, there's no atelectasis. Wound looks good. She's on triple antibiotics. She's already on ampicillin, gentamicin, and clindamycin. She's not getting better. Now, unfortunately, this is not something which is always seen on imaging studies. So it's almost a diagnosis of exclusion. The management is IV heparin. And you give intravenous heparin to double the PTT over what the baseline dose was, and you continue the IV heparin for 7 to 10 days. And you should see a resolution of the fever within 24 to 48 hours. Spiking fevers, day 5 to 6 postpartum. Triple antibiotics, not responding. Yet the patient feels well. Think septic pelvic thrombophlebitis. This is an actual patient, and you can see her temperature goes up, comes down, up and down, up and down, up and down. And you can see why I call it a picket fence fever. And here's a picket fence. Management, IV heparin. What are the risk factors for endometritis? Emergency cesarean, prolonged rupture membranes, prolonged labor. What's the risk factors for wound infection? Exactly the same. What's the risk factors for septic pelvic thrombophlebitis? Exactly the same. It is the emergency cesarean done after prolonged labor, prolonged rupture membranes, which is the big issue in terms of complications, morbidity and mortality. The elective cesarean on demand, much lower risk. It's the emergency one, which is the troublesome one. The last thing we'll talk about is infectious mastitis. This, notice, develops significantly later, up to 3 weeks later, 7 to 21 days. Risk factors: lactational nipple trauma. This woman's nipples are being chewed on like they have never been chewed on before. This baby is biting. The skin is still tender. She develops cracks in the skin. Bacteria from the skin get down, and they cause an infection. Clinical findings: a unilateral localized breastitis. Now, what's itis? Itis is the cardinal signs of an inflammatory response. You have rubor, calor, tumor, dolor, so pain, swelling, redness. That's what you see on physical exam. The management: oral cloxacillin. You want to use appropriate antibiotics, and this is a good board question: continue breastfeeding. You don't stop breastfeeding just because there's some mastitis. Now, I want you to notice the day here. This is postpartum day 7 to 21, 1 to 3 weeks after. What if on postpartum day 3, instead of unilateral, she has bilateral breast findings? The entire breast is swollen, red, and tender. This is not an infectious mastitis. This is what I call a congestive mastitis. This is breast engorgement, and this is classic that happens on almost all women. Now, we don't use suppressants for lactation like we did in the past. They're not allowed by the FDA. Bromocriptine used to be used. So every woman is probably going to get some engorgement. If she wants to breastfeed, then you encourage her to empty the breast, either with a baby sucking on the breast or using a breast pump. If she doesn't want to breastfeed, then use a tight breast binder, ice packs, avoid stimulation of the breasts, and analgesics. And over time, if the breasts are not emptied, they will gradually involute and the engorgement will go away. So, postpartum day 14, unilateral breast findings, single lobe swollen, red, and tender. Bilateral, unilateral. Entire breast, single lobe. Congestive mastitis, infectious mastitis. Management is quite different. I often ask women, are you going to breastfeed or bottle feed? And they say, I'm going to do both. I think that's a good idea. Do you think it is easier for the baby to get milk from the breast or from the bottle? It's much easier to get it from the bottle. Once the baby finds out that it's easy to get milk from the bottle, the baby will say, forget it when offered the breast. So we typically will encourage patients who want to breastfeed, do so exclusively for at least 6 weeks before you start giving any supplementation. Give it a good try. All right, let's summarize what we've just said. This is looking at postpartum fever. Postpartum day 0, crackles in the lungs, atelectasis, most likely had a general anesthetic with a cesarean, management, ambulation, pulmonary exercises. Move around. Postpartum day 1 to 2, costovertebral angle tenderness, dysuria, get a urinalysis, white cells and bacteria, diagnosis, pyelonephritis, management, single agent IV antibiotic, cephalosporin is usually adequate. The most common cause of postpartum fever is endometritis, and the cardinal signs on exam is an exquisitely tender uterus. Risk factors: prolonged labor, prolonged rupture of membranes, followed by emergency cesarean, management, IV gentamicin, IV clindamycin. Don't bother getting cultures. Day 4 to 5, wound purulence, pus coming out. Diagnosis: wound infection, open it up, wet the dry packs, allow closure by secondary intention. Now, I didn't mention this, but we do here. Let's say that she has had triple antibiotics, ampicillin, gentamicin, clindamycin. Wound looks okay. No endometritis, no urinary infection, no lung infection. I would want to just make sure there's not a pelvic abscess. And this you can easily rule out by getting a CT or an ultrasound of the pelvis. If there is one, interventional radiology will be more than happy to do a percutaneous drainage. This is going to be rare, but at least think of it. Septic pelvic thrombophlebitis, no pelvic abscess, no wound infection, no endometritis, no pyelonephritis, no atelectasis, picket fence fever, up and down, patient is feeling fine, wants to go home, management, full heparinization. And ladies and gentlemen, that does postpartum fever.